general theory of complex systems. So let's hear what Vittoria has to talk to us. Vittoria?
So hi everybody. I hope you can listen to me. Please give me signs if you don't listen. Perfect. Okay, great. First of all, let me deeply thank Professor Bleeman and also the other team of organizers for giving me this opportunity to give you a talk also in these conditions. I would like also to thank Marcello and Karen yesterday for helping me, Raquel yesterday for helping me in this effort and technical checks. And last, I would like to thank you in advance, you in the audience, because this is going to be a bit weird, clearly, and I hope it's going to work fine. Most importantly, I'm not going to see what slides you're looking at, so of course I'm going to be coordinated with the person who's moving forward, but I'm not going to be managing the slides myself. So if there is anything wrong, please do terrible signs in the audience. You're allowed to shake, wake up, etc., so that I understand that I'm talking about something that is not in the slide. So I'm ready, and I'll move to the slides. Okay, perfect. So first slide, title, and this is what I would like to talk to you today. It's a series of works that we've been doing to respond to the MERS infectious disease epidemic. And if we go to the second slide, we can see the timeline of cases of MERS, which were published by WHO just 1 week ago, and updated by WHO just 1 week ago. MERS is the Middle East respiratory syndrome. It's caused by a coronavirus, which is causing a severe respiratory infection in humans. Mostly affected Saudi Arabia. More than 80% of the cases have been reported in the country, but it has also been exported to other countries worldwide. And there was also a large outbreak in the Republic of Korea that you can see in red in the timeline. Next slide. If we think about, and if you look about the ecology, what we know so far is that dromedary camels may be a source of zoonotic transmission. We have observed cases that are sporadic or primary cases, so they have been infected by a primary source of transmission, which is now believed to be dromedary camels. And then also we observed a human-to-human transmissions, so a person infected with MERS can also transmit MERS to other persons. And this is clearly the most dangerous aspect of the disease from a public health point of view. There are still a lot of unknowns in the full path of transmission, so we know that there may also be other relevant factors at play, and for the moment we don't know much more than this slide very schematically represents. Now, if we go forward to the next slide, this is the first, let's say, situation that we faced. It was spring 2013, and the virus was first identified in October of the previous year. Few importations had been observed in Europe, one into the UK with a human-to-human transmission detected in a household, and then an importation to France with a human-to-human transmission detected in a hospital. So clearly, French public health authorities, let's say, prompted us in order to try to understand the risk to our friends and also what was the level of danger of this transmission. So what we wanted to estimate at that time were the probability of transmission of zoonotic transmission, so of generating sporadic case, which is this P outlined over there, and then the reproductive number, that is the number of cases that a person can generate in humans during his entire infectious period. And this is the typical estimate that is used for assessing epidemics. So clearly, one of the problems when you want to estimate those parameters, especially the reproductive number, is that you look at the cases in the outbreak area. And if you look at this plot, clearly you can see that there are very small cases. Now, when you have uncertainties and positive data, what usually happens is that it's very hard to estimate these parameters from the knowledge that you have, from the available knowledge. So one possible way around is to estimate the reproductive number, so human-to-human transmission, not from cases observed in the region, but from cases which are instead imported into other regions. And this was first used during H1N1 pandemic. We are at slide 5. Sorry, I forgot. And now we move to slide 6. Thanks for your patience. And this was first used in 2009 H1N1 pandemic, mainly because of problems with the reliability of surveillance data in Mexico. So in order to go around that problem, Fraser and collaborators introduced a backtracking method in order to estimate number of cases in the source region from importations. Clearly, the larger of cases you have in the source region, and then the larger is the probability, and the quicker will it be the spread worldwide. What we did was to numerically simulate this process explicitly, taking into account the data on passengers flying worldwide. So if we go to next slide, number 7, this is the model that we used. It's called GLEAM, Global Epidemic and Mobility Model, and it's an approach that I have been developing in collaboration with Northeastern University and ISI Foundation since 10 years now. It includes different data layers, starting from a population data that maps individuals all over the world in a grid whose size is of 1/4 of a degree. So we're talking about 100 kilometers. Then it also includes daily commuting data in order to take into account the movement that people do to go. Includes also the entire aviation network, accounting for more than 3,000 airports, about 20,000 connections, and on each of these connections we have also the number of passengers flying. This model can be coupled with a customizable compartmental model which needs to target the pathogen or the epidemic that we want to describe. So in order to adapt GLEAM to MERS epidemic, we considered a compartmentalization including latency, so susceptible, exposed, infectious, recovered. This was informed from available estimates on latency and generation time, but the force of infection had to consider the two types of transmission. On one side, the sporadic transmission, which is modeled through this probability PSP, and now I'm in slide 8. Hope I will remember. And the second aspect is instead the transmissibility from human to human, so which is accounted for by the reproductive number. We consider also skewed distribution of individual transmissibility to accounting for the large heterogeneity which was observed in the clusters in the Middle East. If we go to slide 9, I represent, so in a sketch, in a schematic way, the method that we adopted. It was previously introduced for 2009 H1N1 pandemic, and now we wanted to apply it to MERS. Now, what we did was to explore this bidimensional space of R and P values, and for each of these values, we ran simulations. These simulations also provided arrival time of the first infected individuals in given countries. We checked that our estimations were in good fit with the observed and empirical data. And this, through a maximum likelihood approach, was supposed to provide us with the best estimates for R and P. Of course, what happened is that given the very small number of cases and the double possibility of transmission, both from a zoonotic source and human to human, this created degeneracies in the estimation procedure, so that we were not able to disentangle the role of human to human versus sporadic transmission. So in order to improve the power, let's say the estimation power of our method, we had to introduce a novel method that I present in slide 10, that also includes cluster size and the estimation of the reproductive number from cluster sizes observed in the data in the affected countries, so in the Middle East. So this was combining importation elsewhere and cluster sizes locally. Once we do that, we obtain, in next slide, 11, the results which are showing you exactly this parameter space where we have reproductive number on the x-axis and the probability of sporadic cases on the y-axis. And you see that we were able to identify the maximum of this likelihood, indicating that the epidemic was subcritical, meaning that the reproductive number was smaller than 1, and even with a quite large confidence interval, also the maximum value of the confidence interval was smaller than 1, indicating that the epidemic did not reach yet the critical threshold of transmissibility. And at the same time, we were also able to estimate the under-ascertainment of cases. Every time that we have a new disease emerging, we often have the problem of estimating the true number of cases in the affected area, besides what the amount that is actually reported to authorities. And what we found is that the actual number of cases may have been twice the number that was reported. Now, the information, the knowledge on subcritical epidemic was in line with previous studies made by Breban and collaborators and Cauchemet, and also later confirmed by other works as well. And this still, and also later studies including additional data confirmed these estimates, that the epidemic is still below the critical threshold. So going on with time, and now we are at slide 12, we started facing additional problem. This was, remember, the timeline of cases 1 year before, and if we click one more, we get to the situation, slide 13, to the situation that we were facing in spring 2014. What we observe is that there is a large increase of cases with respect to previous year, and more specifically, it seems that there are some waves concentrated around the month of April, or more generally around the period of spring. So everybody started thinking and questioning about the possibility that there could be a seasonal factor affecting MERS epidemic. Also, in addition to that, if we go to slide 14, looking at the distribution of cases in the Middle East, we realized that the geography of the epidemic was not uniform, and that there were some regions displaying a much larger, reporting a much larger number of cases than others. So we started questioning the possible presence of seasonal and spatial factors, so temporal and spatial factors that could affect MERS. And of course, this could affect both transmission, because we are still considering two different routes of transmission. If we go to the next slide, so what we did was to build on the knowledge, methodological knowledge that was introduced in the previous approach, still introduced once again a combined approach, looking at cases importations worldwide, but looking this time at incidence time series. Why we did that? Well, most importantly, because we had a larger amount of data at that time that allowed us to reconstruct more in a more accurate and reliable way incidence time series of cases by regions that then we could model stochastically. If we go to next slide 16, we consider different models and that could account for spatial and temporal dependence, both in the sporadic generation of cases and in the reproductive number. And then more specifically, next slide, if we look at the temporal dependence, we considered a linear spline for the generation of sporadic cases, so zoonotic transmission, and then a stepwise function instead for the reproductive number, whose point of, let's say, change in time were identified by the period of spring in order to fit the data that we saw before. Concerning spatial dependence, we considered the two parameters identifying probability of transmission along the two routes of transmission that could change according to the region. So we have these parameters alpha and beta, which change according to region R. We looked at data from 17 regions. Next slide. 11 regions correspond to 11 provinces of Saudi Arabia, which is the largest country in the Middle East, and then additional 6 countries that were considered. The reason we restricted this work to that region is that because we are not, in these regions, we're not able to distinguish between zoonotic and human-to-human transmission. So very likely we have to consider both, because zoonotic transmission very likely is spread in the entire area. Of course, when we will look later at instead countries which are far away from that region, we would just focus on human-to-human transmission. If we go to next slide, I provide you with an example of this time series of cases, incidents for the region of Makkah. That is one of the regions reporting, there is a region reporting one of the largest outbreaks. And then we also have to take into account among these entirety of cases which are due to sporadic transmission and which instead are due to human transmission. And WHO reports in the entire region at the time when we started doing this work, and now this is not very much changed, reported that 34% of all these cases were due to human transmission, and all the remaining instead were of zoonotic nature. In our modeling, we assumed this is considered for us a complete information scenario, where slide 20, where this complete information corresponds to assuming that we have entire and complete knowledge of what is the source of transmission for the case at hand, and for all cases. And for that, we trust WHO reporting. But also, next slide, we consider instead a partial information scenario that assumed that human-to-human transmission may have been unidentified, so that this fraction could be larger than 34%. Now, if we go back to our models, slide 22, we have two possibilities, so temporal and spatial dependence for each of the parameters, times a complete information scenario or partial information scenario. And if we make this little calculation, we arrive to a total of 32 models stochastic models that we explored. So we fit these models to the incidence case series obtained from empirical data. And our result for the best model that I'm showing on the slide 23 showed that the partial information scenario was much better than complete information scenario, indicated that really there was probably that this type of flexibility in the identification of the origin of transmission was needed in order to best fit the data observed. If we look at spatial and temporal dependence, next slide, number 24, we found that the best fit model was foreseeing the presence of both dependencies in both types of transmission. Now, the most interesting part is that if we look at the second best fit model, and this is slide 25, we observe that the spatial dependence would not be needed in the reproductive number. So what we expect from these results is that while the sporadic generation of cases from zoonotic sources have a strong spatial and temporal dependence, in the case of human-to-human transmission, only temporal dependence is needed to fit the results, while instead the spatial dependence is much weaker with respect to sporadic cases. And we will see also later in the following how this translates into real numbers. If you look at slides 26, I'm plotting here the geotemporal variation of the probability of generating sporadic cases. Here, for each of the regions on the y-axis of the plot, there are two beams. In some cases, only the longer beam that is dark blue is visible. Dark blue corresponds to the spike of the linear spine, meaning what the value of this transmission probability during spring 2014, while instead the smaller value in lighter blue corresponds to the baseline value. What we found is that on average, during the baseline, there was a generation of 6 cases per week, 6 zoonotic cases per week, which increased about 17 times to reach an average of more than 100 cases per week during spring 2014. The two regions experiencing the largest increase during the spring were the Riyadh region and the Eastern province, which are outlined in the map. If we look at the geotemporal variation of the reproductive number, which is slide 27, we observe that in this case we still have variations. Again, once again, the longer beams, the dark blue, correspond to the values during the spring 2014. And in this case, we observe a smaller increase, about threefold on average. Most of the regions are able to go beyond the critical threshold of the reproductive number equal to 1, which is this vertical line, dotted line that you see in the plot. And so putting them in a situation in which the epidemic was actually able to sustain the spread in a human-to-human mode. The two regions having the largest increase are the Maca region and then Eastern province as well. Now, if we focus on the two regions reporting the largest number of cases, which are Maca and Riyadh, what we find is that the reason behind this large number of cases are actually different. In one case, it is due to mostly zoonotic transmission, and in the other case, it is due mostly to human-to-human transmission. And this is in line with some of the other findings obtained from a phylogenetic analysis in the region, and also from additional estimates of the reproductive number in the region of Maca made by Majumder and collaborators. If we go to slide 29, I'm going back to the point that we mentioned before, the fact that the spatial variation appears to be stronger in the sporadic generation of cases with respect to the reproductive number. And indeed, if we look at the plot and if we measure the coefficient of variation, we find a much larger number value for the probability P than for the reproductive number R. So 0.99 compared to 0.20. And this is it seems to be an evidence for the strong environmental component of the zoonotic transmission, which instead is not found for the human-to-human transmission. This is in line if we think about the fact that zoonotic transmission may occur, for example, from dromedary camels. Of course, these may be strongly geographical depending on where camel farms are located. And a large variability is known to occur between regions in Saudi Arabia. And in the case of, okay, I got messages in the meantime. And in the case of, I'm sliding 29 still, sorry, slide 29. I was still commenting that, sorry for that. And in the case of the reproductive number, this coefficient of variation being instead smaller seems to indicate that the seasonal variation is stronger than the geographical one. If we go to slide 30, I'm plotting now, mapping the results of our predictions in terms of primary and local transmissions for each of the regions. And you see that there are indeed large variations, so that the fraction of human-to-human transmission vary with respect to the total. Now, let's remember that WHO reports that 34% of transmission are due to human-to-human transmission. What we found across all over the region, and taking into account of these variations by region, is that 75% of cases are predicted to be due to human transmission. This seems to indicate that a large amount of these cases which correspond to human transmission may have gone unidentified. And indeed, for a large fraction, this is consistent with other studies which showed that a large fraction of sporadic cases have not a zoonotic source, have not a well-identified zoonotic source, so that it was not reported, for example, a contact with camels or a visit to camel farms, etc. So this seems to indicate that our current surveillance may be biased towards a larger number of sporadic cases with respect to what actually is happening in the region. If we go to slide 32, this is the last part of the work that we started doing, and this is still under submission, it's not out yet. Let's say that, of course, some of the works that we did before helped into responding to some of the questions, whether the epidemic was still critical or subcritical in the region, whether there is some variation in time that is important to account for, even taking into account next year's and possible future evolution. But then something happened in 2015, for which the focus of MERS epidemic was not only on the affected area, but also became to be of great concern also worldwide. Let's say a case imported into South Korea, that was the month of May, June, led to a large outbreak locally. Large outbreaks that led to about almost 200 cases, and which are clearly due exclusively to human transmission, as these regions are far away from the Middle East, so we can make the hypothesis, the assumption that there is no zoonotic transmission. And this, of course, was very scaring and concerning for public health agencies worldwide, because so far we had already seen some importations in other countries, and we can go to slide 33, as it is reported on the map. But the large majority of these importations did not lead to subsequent generation of cases, except, and in cases where this happened, the number of cases generated locally were was very small. So it was like in the UK, a couple of cases, in France, one case, and in Tunisia, once again, one case. In all other cases, no local generation of cases was observed, and then South Korea happened, so that everybody went back to the MERS epidemic, especially asking two questions. On one side, whether the epidemic was changing, evolving in order to explain the observed outbreak, or if this was not the case, how to explain the larger heterogeneity observed in the local generation of cases after importation. And this is what we focused on. So we look, this is slide 34, we looked at 22 importations for which we were able to collect detailed history in terms of travel history and epidemiological history. Here are reported in this plot, which is showing with different colors the onset of symptoms, the time, the arrival of the case in the country, and all of these cases are put in line, let's say, are ordered according to whether the time of arrival in the country, so time of importation, if they were symptomatic, or the date at which they started to be symptomatic in the destination country. For example, in the Tunisian case, the case started to be symptomatic on the day of arrival, and so we have that blue stars over there. When instead in the case of, for example, of South Korea, the person was symptomatic while traveling, so we do not take into account the period that he spends in the origin country while it's symptomatic. And since we are concerned about the risk of local transmission in the destination country, we just consider the time from the date of travel. clearly, if you look very, very easily, then we can identify in blue the time spent in the community before being admitted to a hospital. Various levels of red, from pink to red to dark red, indicate instead admission to a hospital. The latter indicates the healthcare facility. So it will be just one if you have a letter A, or A, B, C, etc., indicating multiple healthcare facilities visited. Now, what you can immediately find out just by looking at the plot is that the importation cases generating some cases locally, which are the ones indicating on the left with the number of cases that they generated, and also box around the countries, are on top of these of this plot, showing that they have the longest infectious risk period. And now I'm slide 35. The infectious risk period is the period from date of travel, if symptomatic, or onset date, till the isolation of the case in the hospital. So either admission to ICU or death in some cases. So the longer, and this is also through a regression analysis, can also be shown that is statistically significant, meaning that the longer of the infectious period, then the larger is the probability that the case will generate some cases locally. But then most importantly, and this was one of the important aspects of the study, is that the risk factor, slide 36, is the hospitalization period more than the time period spent in the community. Also, if we building stochastic models taking into account transmission in the two settings, we found out that in the hospital, cases are predicted to produce a larger number of cases than the ones predicted to be produced in the community. And then another factor, which is, of course, driving the risk for local transmission, is slide 37, visiting to multiple hospitals. Now, once again, this could be expected, but it's important to take into account that this may be related also to cultural aspects. For example, in South Korea, it is well known that individuals go healthcare shopping, in quotes, in the sense that they have the habit of visiting multiple healthcare facilities in order to explore possibilities and having different suggestions before deciding what path to take. Now, clearly, instead, this choice may be very different and may be country dependent, in that it may depend, for example, on the national healthcare system, if existent, and what are the policies over there. Another aspect that we found that was very important, and I'm still in the same slide, is, for example, some individual awareness. If individuals were were declaring their travel history once they were admitted into the hospital, they had a shorter hospitalization period before isolation, and so this decreased their risk. Now, taking into account that, of course, awareness was an important point, and also considering that these importation cases occurred during a total of 3 years, so clearly attention and awareness towards the disease and the epidemic may change a lot during time, we looked at possible measures of awareness, slide 38, and in this case, we considered Google Trends data as a possible indicator of public awareness. Digital sources like Google Trends, Twitter, and other sources have been used in very recent years in order to gauge attention, concern, and awareness towards epidemic. So we used Google Trends queries for MERS, and we looked at how this was changing in time. Now, this plot is showing you that you observe several spikes, and typically spikes are due to some events that occurred. So people are reacting and are then are Googling clearly about the epidemic after specific episodes. That could be, for example, importation of the first case in the United Kingdom, importation of the first case in France. This led to a very large reaction also because of the nosocomial transmission. And then in spring 2014, probably this large attention was due to the spring outbreak in Saudi Arabia that we just discussed previously. And then also afterwards. Now, what you see typically in these trends, and was also observed before in awareness studies with regards to the 2009 H1N1 pandemic, is that you have a very large increase, a very rapid increase of awareness, and then these spikes, which rapidly wanes out because attention has a very rapid waning time, so that people are not really then caring for months, not even for the entire duration, for example, of the outbreak. Attention is very short spanned. So we looked at awareness, and then we started looking at, we wanted to identify periods of high attention and high awareness. And we looked, therefore, at the upper quartile distribution. This is slide number 39, in which these gray areas are indicated the periods where attention was high compared to the entire timeline of awareness. And then we wanted to look at what happened at the reaction of the country at cases which were imported during these periods of attention or outside these periods of attention. If we go to slide 40, and this is my last slide, what you can see is that we have cases, typically the ones colored in yellow, which were imported outside periods of a high attention, what we call baseline attention. And the number of days these cases spent in the hospital, which is reported as the quantity on the y-axis on the left, was rather high, so was rather large. If you think about the UK case, the French case at the beginning, but also if you think about the South Korean case towards the end of the epidemic. Now, contrary to that, if you look at cases which are instead visualized in red, corresponding to periods of high attention, these cases were hospitalized once there was a large awareness all over the world about the MERS epidemic, and they were promptly hospitalized and isolated, meaning somehow that the response of the country was accelerated and was prompter and more rapid in terms of managing the case admission in the hospital and its subsequent isolation during period of a high attention than during period of baseline attention. Given that we know that hospitalization period is the main risk factor for generating local cases, this could be an indication for to inform countries to always keep high awareness for importation of MERS cases, which may happen clearly during unexpected periods and for an epidemic that is evolving and unfolding on a very long period for which attention clearly wanes out. There are some exceptions to this separation, that is, to this, let's say, association that is statistically significant. But for example, if you look on the right side towards the end of the timeline, the Chinese case indicated as CH1, that case was imported into China. The case, however, was contracted its infection in South Korea, and then against travel restrictions for infected cases, he traveled anyway to China and was reported immediately to authorities, and that is why authorities were able to handle the case and manage the case very rapidly and to hospitalize and isolate the case very rapidly, because somehow there was a travel history very well known behind that. So overall, clearly, what I aimed to show you was that during different phases of the outbreak, you have different questions. Of course, also different associated challenges depending on the available knowledge. And in different situations, we're able to, through modeling, to partially provide answers to these open questions and provide identified indication that can inform response of different countries. And I would like just to pass to the last slide to thank all collaborators involved in this work, and especially Chiara Poletto, researcher in the lab here in Inserm, who was the main author, the first author of all of this work. I thank you very much for your attention, notwithstanding this remote control, and I hope everything is clear. Thank you so much.
Thank you, Vittoria, for the very interesting presentation. Now we'll pass the word to our audience so that they can pose questions to you and to Crystal as well. So we have plenty of time, I think, for questions. So if you want to.
Thank you. It's working. First, I just have a question for you, Crystal, about the Ebola outbreak in West Africa. You showed the epidemic curves for the 3 countries, and that was very interesting and very striking to me, the difference between the curve in Liberia and Sierra Leone compared to that in Guinea. And so in Guinea, which was the first country to report cases, the thing just sort of trickled along at a more or less a variable but relatively low rate for a very long period of time. Didn't show the same characteristic epidemic curve that you would expect. Do you have any, based on your experiences and your understanding of those data, do you have any suggestions as to what was going on differently there?
I think most people think that there were probably more cases missed in Guinea, so not recorded in the database and not picked up as Ebola cases, but it's extremely difficult to actually pick that up. I mean, what I hope will happen at some point once things settle down is that people will be able to go back into the affected areas and do some sero surveys and actually try to pick up sort of undetected cases.
Well, yeah, so that would be great to be able to assess the under-reporting rate, but it's clearly not just a matter of under-reporting, right? Because that would just scale the curve downward, whereas the shape of the thing is actually quite distorted.
Well, except that if you max out your detection sort of process. So, I mean, because people were coming into health facilities and then getting recorded, and there were people being turned away at the door. So not just turned away at the door, but once people hear that they're being turned away at the door, then even though the health messages come in to us as soon as you can, there's sort of a limit in what you can detect. So there are issues. We've tried to look at ways of doing sort of capture, recapture, but there just wasn't a community level detection of who was being symptomatic. So I think it may well be that they were just in the areas that were most affected, you were just getting beds filled as much as you could. And then until you actually had a ramp up of effort, then there was a limitation on how many cases you could see. So these are really important questions, but they're quite hard to actually distinguish for that reason.
Any more questions? Well, I have a question. So I have a question first for Crystal. You mentioned all the challenges regarding handling the data, problems with fixing up the addresses, the years and all that. And everywhere, I think everywhere in the world, I can say it for Brazil, it's a big challenge when we get data which is not in such a emergency situation, and still we find so many irregularities in data recording. And I would like to hear your impressions on what was the effect of the WHO intervention on the improvement of healthcare information processing and maintenance and regular collecting in these countries after you left, if there was any.
It's really quite difficult to tell because in a sense we don't have what data was there before it was going into the data, so we have the database as set up. So that there was already pre-existing before Ebola, there was a viral hemorrhagic fever, VHF database structure that was set up. And so that was then rolled out areas to use. But what we don't know is, sort of what was being recorded before that was brought to them, because we don't have that data. I mean, what may be possible is to go into some of the very early responders, like maybe Médecins Sans Frontières, and see what they recorded before and then how it got in. But the other thing that's difficult is that there's some data that was sort of written but not entered into the databases. And so even, the time series that we projected in September 2014, when we then went back in December and did further projections, some of the September numbers had changed because things had been filled in retrospectively. So we do have snapshots, so we can look at some of that. So some of that was, just, that there were forms and they weren't being entered. I mean, there were some places where, there were difficulties in how do you get the forms out, because you're not supposed to take things out of an Ebola treatment center for, control reasons. So there were actually cases where people were standing on different sides of, quite a big divide, shouting out what was written on the form so it could be entered by somebody who, so that the information could be taken away. So I think things will be done differently if there was, more time and thought. But I think, both the CDC, who also responded, and they were the ones who had actually set up the VHF database, both WHO and CDC, have infrastructure there, but they need the people to interface with it and to be trained on it and all those things. So there will inevitably, there are a lot of people who've been trained now that weren't trained before, but there are also, people who had medical training that have been killed by this epidemic because it hit the healthcare workers so hard. So, there will be aftermath, but it's important that it doesn't just concentrate on these three countries, because although it happened here, there are countries like Rwanda is sort of geared up to deal with Ebola because they've dealt with it before, but there's some other countries where it could occur that haven't had Ebola outbreaks now, and the world needs to be sort of ready and responsive for those so they don't end up being the next big Ebola outbreak.
Thanks for both talks. They were very interesting. I have a comment and a question for both presenters, Crystal and Vittoria. One thing that was mentioned in both talks, and it's the great impact of information and awareness, both from the population side and from the healthcare workers themselves, and the problem that it brings. So in the case of Ebola and SARS and MERS, that we have symptoms that are similar to other diseases that are not so, that don't have such a great impact. And then healthcare workers dismiss patients with those symptoms, thinking that it's something else, and this affects how it leads to new infections. And my question is, if any of you have any suggestions on how can we work towards increasing awareness in those situations, both to public and at healthcare facilities, in order to also try to bring down and prevent new cases. Thank you.
Vittoria, do you want to start?
Yeah, sure. This is a very good question, and I believe it's the central issue of much of the public health debate nowadays. So the easy answer is communication, but it's not always the case. For example, in the case of MERS, right after South Korean importation, there was an importation in the Philippines, which was handled very rapidly. And this is also thought because of the very strong local communication that public health authorities did really in the place of importation. So they really asked everybody, if you have a couple symptoms of this type, please behave and contact the authorities if you're coming back from those countries, etc. So clearly there is, let's say, an institutional kind of effort to be made that in some cases may work. Historically, this was proven to be the case, for example, for SARS, but on that, Crystal has made one of the most important papers, so she can answer better than me, and where you saw that people were going to the hospital more rapidly after the onset of infection. They were not waiting. So this was prompted, of course, by the authorities, but also because of individual awareness in terms of a concern. Now, I think there is a strong difference to be made between an epidemic like SARS, it's rapidly expanding, and you have an increasing number of cases, so concern doesn't wane out. And the situation with MERS, which is there since 3 years, somehow is far away, is not affecting our countries. And when we get one case, of course, we are somehow unprepared because we're not thinking about that specific possible cause. In that, what it plays, I think, a very important role, and this is very well known in epidemic surveillance, is that for importation of cases, history of travel is the very first indicator. So that's typically the first question that a doctor has to ask. And it's also the first thing that a patient himself has to declare, even before the diagnosis. Because sometimes, as you say, diagnosis may be mistaken, and the MERS infection can go for, I don't know, a severe flu infection, for example.
And I think it's important with that it's not just the doctor who's asking that or hearing that, but the person, if you come into the emergency room and you're being triaged, that would be a good, that's a good time to have that question. Have you traveled somewhere? Because, you may not have complete isolation rooms, but you can at least put somebody a bit further away. I mean, there were certainly, taking the SARS example, there were transmissions within hospitals, even by people who were in nearby beds in the emergency room. So that can happen even if you sort of separated people a bit, but it's how long you sit there. And this hospital shopping that Vittoria talked about, that can end up with people for hours in multiple different waiting rooms. And so the high potential for onward transmission. It's difficult to maintain both sort of vigilance and duration. I tend to panic with my kids. Oh, you've hurt yourself. But, you sort of burn through that for a while. And so, people will get tired if they, keep looking for something and they don't find it. But it's just important that it's part of the protocol and what you do. It's easier in places where you don't have a lot of travelers than if you're running a hospital in the middle of London and you will have people traveling around to lots of places. That's difficult. And it's important to sort of have an appropriate level of response. But with something like SARS, where it came out of nowhere, it's just, you can't be prepared to that. You just have to be responsive. And there were cases where treatment actually increased transmission. There was use of nebulizers in one of the hospitals early on, which seemed like a good way to get the drug in. It also turned out it was a good way to get the virus out. And it led to a bigger outbreak in one of the hospitals. Which is not to blame the person who, suggested that. It's just, they just didn't realize what they were dealing with. So it is difficult, but there are, when you actually look at severe outbreaks and sort of things, if it were MERS, but with a much higher reproduction number, most cities don't have a lot of truly isolated rooms. We could gear up. London had this amazing facility for Ebola patients brought back, but it still wasn't, it was because they expected very, very small numbers of cases. So we can't expect everybody to be available with, a large number of cases. But it's just, the more that we have these examples and learn what good practice is, hopefully we'll be ready next time. But it's a lot easier if you're dealing with SARS in Hong Kong, obviously, because you've got the hospitals and you can deal with that. But it's also people realizing that, seeing a benefit to coming into treatment. So one of the issues was that early on in some of the communities, people would, sort of be picked up. So you could come in and say, oh, you've got Ebola. And then those people go and they never were seen again. And there was no feedback. And so, because most patients die. And so it's possible that some places they didn't see anybody come back who'd had Ebola, or even just, they might be gone for 3 weeks. And then people are thinking, they just disappear. They never come back. So then you're scared to tell them if you think your child's sick, it's better to keep them at home. So it's really important, to realize, but it's an incredibly difficult thing. I have multiple children. What if one was sick? And then, so you're scared for the one that's sick, but you're also scared for the one that's not sick yet. And trying to communicate those, and also realize that what people may see as the best strategy for them individually is not the best strategy for everybody. If I'm in an area that's been quarantined, but I have a chance of getting out and I'm not sick yet, that might, rationally, that might be the best thing for me, even though it's worse for the community. And trying to balance those things is really difficult. There's no answer that's going to make it best for everyone.
Sorry, at the risk of keeping everybody here for far too long, there was a couple of things that were really interesting in both of your talks, and I wonder if I could ask each of you one question. So, first, Crystal, fascinating this extra binomial variability in the fatality rate. I wondered just quickly, did you look for geographical clustering in that? Is there any suggestion that it might be something to do with nutritional status or anything like that?
We did look for geographical clustering, and there wasn't a lot. I mean, it varied by country. But once you adjusted for country, we couldn't find anything. It's difficult because some of the, the sample size isn't that great, so there may well be that. What we don't have is good measures of the state people were in when they came. So it may well be geographic variation, masking those things. We tried to look at what their treatment regime was, but it was difficult to get information on that. So, it's more to be explored. But you'd certainly, you'd like to know a lot more about what the baseline population was to begin with than we do.
And then, thank you. And then, Vittoria, maybe a slightly technical point, but I noticed, I think I gathered from your talk that the key piece of information that allowed you to distinguish between the spontaneous acquisition of infection and human-to-human transmission was the cluster size distribution, but you didn't tell us very much about how, well, let me just say this. So then you also pointed out that there was substantial underreporting, or seemed to be evidence for substantial underreporting. Given that those two things probably interact in a pernicious way with one another, how did you check to see that given the variability you'd expect in the cluster size reconstructions, that your conclusions were robust to that?
Yeah, that's a very good point. So what we did was we used the cluster size in order to have a first estimate for R. The model we used also allowed for underreporting in the clusters. So we also allowed for different sizes that were observed. Then this first estimation of the likelihood was integrated, so it was really multiplied with the likelihood obtained on importation of cases, which in principle was supposed to be able to provide both the reproductive number estimation and also underreporting. It provides underreporting simply because given that we are looking at importation of cases, we're not actually assuming any number of cases in the region. We are estimating that. So once we estimate the number of cases in the region, then we're able to simply evaluate the underestimation as a ratio between what we estimated from importation to what is reported. So in that sense, the estimate that we provided, let's say, was robust to underestimation to the extent that we considered underreporting in the cluster size analysis.
Thank you.
So if there's no more questions, let's thank the speakers again for this wonderful talks. And now we'll go to a coffee break, and then we'll come back for more talks. We may have approximately 20 to 30 minutes for coffee break.
So, Vittoria, thank you very much for this experimental plenary talk, and really.
Thank you, Marcello. Thank you, everybody, for the patience. Okay. I'm so happy. I mean, from here, this was not easy, but I'm so happy. You can't imagine.
Yeah, it was really great, and I think it was quite transparent to the audience. So, really, it was a success. Well, next time you'll be here. Let's hope.
Thank you. Looking forward to meeting you next time. See you.
Okay. Goodbye. Goodbye, Vittoria.